is approach to the patient with connective tissue disorders. This is a clinical type of discussion because when you go to hospital and you start working, a lot of these type of cases would come to you. Okay, these are called connective tissue disorders like SLE, rheumatoid arthritis, dermatomyositis, polymyositis, Sjogren syndrome. Many different types are there. So how to take history, how to approach with physical examination, how to order investigation. So let's talk about that. So see there. Okay. So connective tissue disease or connective tissue disorders are a group of closely related multi-system condition, and they share common signs and symptoms with each other. So they share common signs and symptoms. This is the important point. Frequently, they make the diagnosis of specific rheumatic disease difficult because they are sharing so many common signs and symptoms. So we cannot really pinpoint which type of a disorder is this. Rheumatoid arthritis, SLE, systemic sclerosis, also known as uh, scleroderma, or systemic sclerosis, polymyositis, dermatomyositis, and mixed connective tissue disorder, along with Sjogren syndrome, they can present with similar clinical features, particularly during the first 12 months of symptom. Like many of them may present with skin rashes, joint pain, okay, a multiple involvement of the inner organ of our body like kidney involvement, lung involvement, okay, vasculitis. So because of this, we often confuse with each other. But this approach is all about that. If we follow certain pattern, then we can able to diagnose them. Now, the key clinical features of these connective tissue disorders are, okay, see here, they involve the skin, joints, muscles, or blood vessel. In one sentence, I can say they involve the whole body. Whole body, okay. The manifestations are very diverse: skin, joint, muscles, or blood vessels. Connective tissue disease are associated with antibody against the variety of anti-nuclear antigen. Okay, they have. If we send the investigation, ANA is positive in many of them, or all of them, I can say. ANA is one of the important antibody which is present in connective tissue disorder. So that's why this is sensitive but non-specific type of antibody, ANA. Now, internationally agreed criteria do exist for many of these disorders. Okay, one of the example I can give here is SLE. Okay, there is ACR. Okay, American College of Rheumatology criteria for the diagnosis of SLE, and there are 11 criteria. Out of that, 4 criteria at one time or serially are enough for the confirmation of diagnosis. Okay, and anybody can tell me what are those ACR criteria for SLE? Yes, anyone please? Anybody knows this? If they know, they can answer here. Anyone? Now, they are different type, like they are malar rash. Malar
Yes,
rash, isn't it? What is malar rash?
is we also, sir, the rash on the face, both sides.
Butterfly rash
Butterfly
Exactly.
rash, sir.
on the nose.
Exactly. It is known as butterfly rash or malar rash. It's a highly typical. I've included few pictures here. Later on, you can see highly typical of SLE. Okay, it includes both cheek and the connecting the middle part lying over the nose exactly looks like a
Yes.
butterfly. So butterfly rash or malar rash is one of them. Then discoid rash, disc shaped rash is called discoid rash. Then photosensitivity, photosensitivity, when that type of ladies, they go to sunshine, they they feel very, like itchy type of
Uncomfortable.
sensation. Exactly, itchy type of sensation. They may develop some rashes also sometimes because of that sunburn. Easy type of sunburn or itchy sensation is called photosensitivity. So many other people also have that type of feeling. There are so many reasons for that. And oral ulcer, oral ulcer, ulceration inside the oral cavity. These are typical features of SLE. Apart from there, okay, there are few blood tests like ANA is itself, one criteria. Then anti-double stranded DNA, anti-SM antibody called as Smith antibody. This is another criteria. And then different systems involvement like cardiovascular system involvement, neurological involvement,
Renal.
renal involvement, hematological involvement, okay, arthritis. All these constitute 11 criteria out of ACR, and then for our diagnosis, we just need 4. So any medical student can diagnose SLE if they remember this criteria. So other disease can also have this criteria. So diagnosis is not that challenging these days. Let's move on. Now see there. Considering the diagnosis in a case of connective tissue disorder, okay, these are the very non-specific feature like fatigue, okay, fatigue or easy fatigability, arthralgia, myalgia, depression, malaise, weight loss, fever, and lymphadenopathy, which is common in so many other infections like viral infection, bacterial infection, tubercular infection, even in malignancy. All of these are common. That's why they are known as non-specific feature. But in connective tissue disorder also they are present. So these differential diagnosis exist if these non-specific features are there. Fibromyalgia syndrome, hypothyroidism, and depression are important differential diagnosis of connective tissue disorder. Now let me tell you some concept here. If a patient comes to us and if that patient has multiple symptoms, multiple, like some symptoms in the head and neck area, some symptoms in the limb area, some symptoms on the chest, abdomen, or lower limb, or even genitourinary, there are few possibilities. Number one, this patient may be a patient of connective tissue disorder. That's what we are talking right now. Number two, the patient may be having cancer, okay, disseminated type of cancer or paraneoplastic syndrome. And third, this patient may be a psychiatric patient. Okay, the third possibility is the most common one actually. The patient is having so many symptoms from head to toe. Not many, organic disease or physical diseases can present like that. But sometimes they do. And one of that condition is connective tissue disorder. So this is a golden statement in clinical medicine. Rule the physical diseases or organic diseases first. Rule them out before you label this patient as a psychiatric patient. Once the level of psychiatric patient is done, then whoever doctors look that patient later on or examine that patient later on just overlook, yes, this patient probably is a psychiatric case, is a mental case, like that. So before you label that, to detail investigation, detail examination, take a good history, just rule the physical things out. Then if nothing is there, then think about psychiatric illness. Never forget it. Now, what are the suggestive features, okay, for connective tissue disorder? There may be Raynaud phenomena. We'll talk about this Raynaud phenomena, okay, in today's class. There may be dryness of the mucosal surface or ulceration. There may be inflammatory arthritis, which are highly typical of connective tissue disorder. Many of them are having arthritis. And there may be different type of skin rashes, like photosensitivity rash. There may be mucosal ulceration. Okay, there may be discoid lupus, disc-shaped rashes, which is present in SLE. There may be tightness of the skin and puffiness of the digit. Tightness of the skin and puffiness of the digit. Now, tightness of the skin is seen in systemic sclerosis or scleroderma, and puffiness of the digit may be seen in similar condition, or in case of dermatomyositis as well. Okay, I have included a few of the picture. You can see that a bit later on. Now, considering the diagnosis, we can have some other suggestive features here, like muscle weakness, also known as myopathy. In connective tissue disorder, there is proximal type of myopathy. Proximal, not distal. Distal myopathy are the feature of neuropathy. Okay. Now, recurrent unexplained fetal loss equal or more than 3 and usually in mid-trimester are some other features. Okay, in reproductive age group, unexplained fetal loss, there may be intrauterine fetal death, there may be stillbirth. Okay, so this is important one, or sometimes maybe abortion. Pleurisy in the absence of infection. Now, what is pleurisy? What do you mean by that? Anyone? What is pleurisy? This is pleuritic pain. This is pleuritic chest pain, involvement of pleura. So this is caused by inflammation here, inflammatory type of pleuritis. Okay, so this is a localized type of pain. Sometimes it may be referred also. And vascular event like myocardial infarction or stroke at an early age. Now these days, a lot of younger people are having stroke or MI, and they are dying quite early. This may be one of the cause for that. Now, what are the other causes of early stroke or early MI? Yes, anybody?
Sir, hypertension.
Okay, hypertension. Yes, good.
And sir, and coronary artery diseases are myocardial infection.
Yeah, but what is the cause for that? That is the question. Yes, why young person can develop MI? How? What is the mechanism or cause?
So due to heavy sport activities, like some athletes, and
coronary artery disease is due to the atherosclerosis, smoking.
Okay, heavy smoking, fine. That is considered as one. Yes, heavy smoking from the early age. Yes, hypertension. Now,
hypercholesterolemia.
Exactly, hypercholesterolemia, especially familial type. Now, there is a condition known as familial hyperlipidemia. Familial hyperlipidemia. That's what I want to discuss here. This condition, familial hyperlipidemia, is associated with very high level of LDL in our blood, because it is associated with deficiency of LDL receptor. So LDL is very high, and it can lead to very early atherosclerosis in the patient, and that atherosclerosis is associated with stroke, MI, peripheral vascular disease, mesenteric arterial disease, and so many other things. So don't forget that. Okay, now let's move on. The presence of one or more of these, particularly in combination with non-specific feature together, increases the likelihood of connective tissue disease in this case. Now let me combine few of the features here, like patient is lethargic, patient is having myalgia, arthralgia, okay, in most areas of the body. Along with that, patient is also having proximal myopathy or the muscle weakness. Patient is having some amount of vascular event. So if you combine all these things together, a good doctor will definitely think about connective tissue disorder as one of the cause. That is the point. Now, what is Raynaud phenomena? See here. I'm sure this is not a new term for you. Raynaud phenomena is due to variable spasm of the digital arteries, means arteries which are present in our finger. When spasm is severe and blood flow absent, the digits appear white. So this is known as Raynaud phenomena, but actually this is a combination of three things going together. Three things. One, in the beginning what happened? There is a spasm of the digital artery occurs. Spasm of the digital artery occurs. Now, whenever there is spasm, there is no blood flow, so that area looks white. This is the first thing. After that, if it is continued for a relatively longer period, that site becomes blue because it develops cyanosis. And third one, when the patient recover from this spasm, suddenly a brisk amount of blood flow occurs there. Okay, then that area looks red. So, one after other, white, blue, and red. These three things together is called Raynaud phenomena. Raynaud phenomena. See that? In the beginning, it looks pale. Pale is white. Then it becomes blue, cyanose. Then it becomes red. So one after other, okay, these three things together is called Raynaud phenomena. Now, Raynaud phenomena affects approximately 5% of the general population. Here, and it is important to differentiate primary from secondary causes. So sometimes it occurs on its own. Sometimes there are some secondary causes for that. Primary Raynaud phenomena usually begins during the teenage years and early 20s, and it represents an exaggerated physiological response to cold stimuli. Now, all of the patient do not develop this, but some of them develop excessive reaction to the cold exposure. For example, if their hand is exposed to colder environment, they can simply develop the three things one after other, and this is known as Raynaud phenomena. And in this condition, usually they are not associated with any other disease entity, like it is not caused by connective tissue disorder in them. This purely is a separate type of entity. On the other hand, development of Raynaud phenomena at an older age, see that more than 30-year-old, especially in male, suggests the possibility that it is secondary to some underlying connective tissue disease, and this should prompt investigation for an underlying cause. And that's what we are talking it right now. Okay, so it may be one of the manifestation of connective tissue disorder. Remember, Raynaud phenomena. Raynaud phenomena occurs in 90% of the patient with systemic sclerosis, and in up to 50% of cases with SLE and idiopathic inflammatory myositis. All of these are example of connective tissue disorder. Scleroderma, SLE, and inflammatory myositis. Now, in a patient with Raynaud phenomena, any of several additional features, okay, makes a secondary cause of Raynaud phenomena more likely. Now, what do you mean by this? If these features are present, there is more chance of connective tissue disorder, which is causing Raynaud phenomena, rather than it is a primary one. And those features are, okay, digital ulceration or symptom throughout the year, whether it is exposed to cold or not. Abnormal nail fold capillary. Abnormal nail fold capillary, if it is viewed with an ophthalmoscope with +20 lens, we can see these nail fold capillaries there, and if they are present, we think strongly about connective tissue disorder here. Asymmetric upper limb pulses or bruit. Now, what is bruit? What do you mean by bruit? Yes.
Sir, abnormal sounds.
Yes, say it again. Yes.
Sir, abnormal sound anywhere in the body, not in the heart.
Okay.
That we call.
Good. Now see here. Let me clarify his answer here. Bruit means if arteries are narrowed. Okay, arteries like anywhere in the body. You're right. Anywhere. It can be renal artery. It can be popliteal artery. It can be mesenteric artery. Any other. Carotid artery for that being, if it is narrowed by atherosclerosis, thrombosis, okay, or any other thing, and when blood passes through that narrow area of the artery, a sound is heard, and that sound is almost like murmur, which we hear on the heart. That is called bruit. Okay, so you can say murmur-like sound, which is heard from the arterial site, is called bruit. And examiner will understand itself like bruit occurs because of the narrowing of the artery. So asymmetrical upper limb pulses or even lower limb, whatever, can happen in case of Raynaud phenomena, because in finger it is very, very common. That's why upper limb pulses are written here. Tightness and puffiness of the finger skin. This is a feature of scleroderma. Elevated ESR, very common in any type of connective tissue disease, any type. ESR is high because of inflammation. And then positive ANA or other antibody, if you do investigation, see that ANA is very sensitive, highly sensitive. So it is present in probably 100% of the cases, but it may not pinpoint which disease is there. And for that, I need to go for certain other test like anti-Rho or anti-La or anti-SCL70 antibody. Now see this, SCL, systemic sclerosis or sclerosis, SCL. This is the way you remember, and it connect it with the systemic sclerosis or scleroderma. Scleroderma, anti-Rho, anti-La, and anti-SCL70 antibodies are present. So this will give us a diagnosis. So similarly, double-stranded DNA, okay, anti-double-stranded DNA antibody is seen in SLE. Anti-topoisomerase antibody is seen in some other conditions. So like that, we can give different reasons here. Okay, so this is the way. If Raynaud phenomena is there in the patient, and the patient also having these features, then we think about connective tissue disorder. Otherwise, if the patient is quite young, especially female, and she is developing Raynaud phenomena when she is exposed to cold, it is highly unlikely that she is having other connective tissue disorders inside her. So this is what Raynaud phenomena is all about. And in pathology, I have taught you a long time ago, Raynaud phenomena, okay, whether it is, if it is a primary disorder, we call it Raynaud disease also, if it is a primary type of disorder. Dryness of the eyes or mouth are common subjective symptom in the general population. So many disorders can produce that, but connective tissue disorders are one of them, especially Sjogren's syndrome. But before we think about Sjogren's syndrome, we have to rule out some other common causes like menopause, especially in female, when there is the menopausal age group, or when the menopause is about to happen, they develop dryness of the mouth as well as throat, very common symptom. Diabetes, one of the commonest symptom is dryness of the mouth in case of diabetes, and that can be an early symptom in the diabetic people. This is because of hyperglycemia and dehydration, because they produce large amount of urine. Drugs such as antidepressant and anticholinergic are also associated with such symptom. Now, give me some of the example of antidepressant drug. Yes, which are antidepressant? That can result in uh, uh, dryness of the mouth. Which are those drugs? They are TCI, TCA, sorry, tricyclic antidepressant. TCA, we say tricyclic antidepressant. Remember amitriptyline and imipramine as the important example, and we have to counsel this to our patient. If they take those important drugs, they develop dryness of the mouth, so they should drink a little bit more fluid. And anticholinergic, dryness of the mucosal surface is a non-side effect like atropine, okay, hometropine, and all those types of anticholinergic drugs. Now, having excluded them, then think about Sjogren syndrome, especially if these are the features present, like persistence of daily ocular or oral dryness for more than 3 months, prolonged type of dryness, recurrent sensation of sand or gravel in the eye. Okay, this is another features of Sjogren syndrome. Recurrent sensation of foreign body sensation in the eye. Using tear substitute for more than 3 times a day. This is also not normal. Okay, it shows keratoconjunctivitis sicca. Frequently drinking liquid to aid food swallowing. Another features, because there is no secretion there. Okay, no secretions. The mucous membranes are getting drier. Recurrent or persistent salivary gland swelling or infection in an adult. The salivary gland swelling, especially parotid gland swelling, is seen in Sjogren syndrome. Abnormal Surmer's test. The Surmer's test is a test which is done to know how much tear the patient is producing. Okay, this is one of the diagnostic tests for Sjogren syndrome. We'll talk about that toward the end of this topic. And elevated ESR or positive antibody like ANA, Rho or La, or anti-Rho or anti-La. These all are important part of the diagnostic process. So this is the importance of knowing dryness of the mucosal surface, or we should ask certain questions regarding this in the history taking. Let's move on. Now let's talk something about the inflammatory arthritis. If patient is having this arthritis, okay, how we know these are associated with connective tissue disorder? Joint inflammation is associated with joint pain and stiffness, which last more than 1 hour, and most of them are early morning joint stiffness. This is typical. This needs to be distinguished from arthralgia. Okay? Arthralgia means only joint pain. Arthritis is inflammation of the joint. So these are a very important difference. Arthralgia is seen in some other condition like fibromyalgia or hypothyroidism also, and they are also quite common in general population. In addition to rheumatoid arthritis, okay, this may also be presenting feature of different connective tissue disease. Now, remember one thing, SLE, systemic lupus erythematosus, there is no term called arthritis there. Dermatomyositis, there is no term called arthritis. Polymyositis, there is no term called arthritis there, but still many of the connective tissue disorder, they affect the joint. And rheumatoid arthritis is easier one for the students because arthritis is mentioned here. So they believe, yes, joints are affected, but other type of connective tissue disorder also joints are affected. And they are usually arthritis rather than arthralgia. Now let's talk about skin rashes. What are the different types of skin rashes which can be seen in connective tissue disorder? One type is photosensitive rash or photosensitivity itself. This photosensitivity I've already explained to you is abnormal sensitivity to sunshine. Now, when we go to sunshine, when especially that type of patient go to sunshine, they feel very uncomfortable. They feel that itchy type of sensation in most part of the body. It can also result in erythematous eruption with or without blistering. The whole skin may become red, and sometimes there may be blister formation also. This is the reaction of photosensitivity. This rash frequently involves the bridge of the nose and malar area and classically spares the nasolabial fold. These are typical features of SLE especially. I have collected some of the picture, okay, and we'll discuss showing that picture a little bit later. Second one is recurrent mucosal ulceration. This is especially present in the oral cavity. So we also call them oral ulcer if they are present in the oral cavity, but not always, sometimes they are present in other mucosa also. These also resemble idiopathic aphthous mucosal ulcer, aphthous oral ulcer. Aphthous ulcer are idiopathic. We don't know the cause, and they are quite painful type of ulcer and a recurrent type of ulcer. So they may resemble that. Sometimes they are also present in nasal mucosa. Another type of skin rash is called discoid lupus rash. Okay, this is a discrete means easily identifiable and raised rash associated with hyperkeratosis. There's excessive keratin deposition there. It looks like a fleck from the surface. It frequently results in cutaneous scarring and pigmentary change because active type of inflammation is going on there, which results in scar formation. These rashes are photosensitive, and when they involve the scalp area, they leads to patchy type of hair loss. Patchy type of hair loss, and that patchy type of hair loss is permanent type of hair loss because it is caused by scar formation. So this is cicatricial type of hair loss. Cicatricial. Remember when we talk about the topic of alopecia, we divided alopecia into two important types: cicatricial or scarring type of alopecia and non-cicatricial or non-scarring type of alopecia. This is the one which leads to scarring type because of inflammation there. Now, let's see some of the picture here. All of you, please look at this picture and tell me what can you see here. Yes,
Malarish.
exactly.
Malaria, sir.
Very good. Malar rash, or you can say butterfly rash, right?
Malaria.
Yes. This is malar rash or butterfly rash. This is the wing of the butterfly, and this is the main body of the butterfly. It's right here. So it has to be seen like this. Otherwise, some other differential diagnosis come into the picture. Only malar rash can be seen in mitral stenosis as well, but the middle part is missing there. Okay, so mitral stenosis is one of the differential diagnoses of malar rash, but there is no middle piece there. So it's very typical of SLE. Another one, this is extensive type of involvement. Extensive. A component of photosensitivity is also there. Now, see there is a malar rash.
Discoid type, sir.
Exactly. Discoid type, photosensitivity, and malar rash all are combined here together. Okay, this is extensive type of skin reaction. Now look at here. This is Raynaud phenomena, but you cannot see all those three changes at a time. You need to take three pictures one after other, but it's clearly very white looking.
Pale.
Isn't it? Pale. It's very pale.
Yes, pale.
Yeah. So pale is the first stage. After pale, which stage comes in Raynaud phenomena?
Bluish.
Very good.
Bluish.
And ultimately, at the end, which color comes?
Red.
Red.
Reddish.
Reddish. Excellent. Pale, blue, red, one after other is called Raynaud phenomena. It can be a disease by itself, or it may be a manifestation of connective tissue disorder. This is another type of manifestation on the skin, which is known as livedo reticularis. Look at this thickened type of skin with a lot of capillaries and the blood vessels seen from the surface. Livedo reticularis. It may be a feature of connective tissue disorder. Now, this is alopecia, loss of scalp hair. This is a patchy type of hair loss. Okay, not uniform. Uniform means should be everywhere. But it's a patchy type of hair loss. Now, let's move on. Another important types of presentation in connective tissue disorder is, skin tightening. Tightening of the skin, different types of, problem on the skin. There is a condition known as systemic scleroderma. Please mute yourself. Systemic scleroderma, or systemic sclerosis. There is an initial puffiness or edema of the skin. Puffiness means slight swelling, particularly okay, let me mute all of you for some time because there's a lot of problem from that side. So in systemic sclerosis or scleroderma, there is initial puffiness and edema of the skin. Later on, that affected area will become hard, or it will become fibrosed. Okay, this is a feature of scleroderma. So in which stage you have examined the patient, it depends on that. In the beginning, there is puffiness and edema of the skin, and later on, okay, it will convert into very thickened type, very fibrous type. I cannot pinch the skin from there. The skin is attached right there on the bone. That type of feeling will be there. This is known as tightening of the skin, highly suggestive of scleroderma. Now, look at this picture, another picture here. This patient is a SLE patient, and there is interarticular dermatitis. Okay, interarticular means in between the joint. See, look at this rashes on the skin. Okay, these are some of the manifestation. Another type of manifestation is muscle symptom. Okay, muscle symptom. So let's talk about that. There are some type of connective tissue disorder which have the predominance of muscle symptom, like polymyositis and dermatomyositis. Dermatomyositis have skin involvement along with the muscle, and the type of muscle involvement there is proximal muscle weakness. Okay, I'm sure every student know the meaning of proximal muscle in our limbs. So in the upper limbs, which are proximal muscle, and in the lower limbs, which are proximal group of muscle? Yes, which are the proximal muscle in the upper limb? The arm muscle and the muscles of the pectoral girdle are the proximal one in the upper limb, and in the lower limb, the gluteal muscles and the thigh muscles are the proximal. It's a very easy one. So they are weaker in connective tissue disorder. They may be accompanied by tenderness or wasting. Okay. Now, one of the important investigation we can go for is creatinine kinase here. This creatinine kinase would be elevated in this condition because muscle is damaged, and this is an enzyme which is present inside the muscle. This is CKMM. There are 3 different types of creatinine kinase. Okay, we call it them isoform or isotype. CKMM, CKMB, and CKBB, isn't it? CKMB means you have already studied that CKMB is present in heart
muscle, heart muscle
or cardiac muscle. Okay, CKMB, it is elevated in myocardial infarction. CKMM is from the skeletal muscle, which we are talking right now, and BB is from the brain. Now, after doing all these symptoms, whatever the patient can present, let's talk about some important physical findings which are there in connective tissue disorder. And I have collected some of the picture for this as well. So telangiectasia is one of the important skin finding in case of connective tissue disorder. Telangiectasia means dilated superficial blood vessel. Dilated superficial blood vessel, which are quite common there. Purpura and petechiae may be present as a physical finding. These are skin bleeding. Digital ulcers or scar may be quite common. These are because of ischemia. Remember Raynaud phenomena. There is spasm of the blood vessel, which is taking blood to the digits or finger. So towards the tip of the finger, there may be slight ulceration or scar formation because of that. Sclerodactyly. What is the meaning of this? Anyone? Have you heard this term before? Sclerodactyly. Anyone? Okay, fine. This is a feature of scleroderma. Scleroderma or systemic sclerosis, where the finger are tightened up. The skin is attached right on the finger, and we cannot extend the finger so easily. The fingers develop a bit of clawing. They are a little bit flexed because of too much tightening of the skin. This is known as sclerodactyly. It's a feature of systemic sclerosis or scleroderma. Never forget this important MCQ question in the exam. Now, another one is acroscleroderma. Now, acro is acral part or the peripheral part. Acral or peripheral part. So, skin is getting thicker there. Calcinosis is a deposition of calcium. Now, there is one condition. I'm not sure whether you remember this or not, but you have already gone through this, known as CREST syndrome. CREST syndrome. This is a feature of scleroderma or systemic sclerosis. Now, anybody remember what is the full form of this CREST syndrome? Anyone? See here. So let me clarify this. C stands for calcinosis. Okay, C stands for calcinosis. Calcinosis, which you can see right there. R stands for Raynaud phenomena. Okay, Raynaud phenomena, which you have just studied. Raynaud phenomena. Now, E stands for esophageal dysmotility. Esophageal dysmotility, because of the deposition of those different type of substances. Okay, this is the hallmark of systemic sclerosis. There is poor contraction or poor motility inside the esophagus. So person will have dysphagia. S stands for sclerodactyly, which we have just talked about. Sclerodactyly. Here, sclerodactyly, and T stands for telangiectasia.
Telangiectasia.
Exactly, telangiectasia. So these are the different things which we see in CREST syndrome. Don't forget, this can be an important question for you in the exam. CREST syndrome. Okay, so see there. Now, some other features would be rashes like malar rash or discoid rash, which you have already saw the picture. Erythema nodosum. This is a painful type of node or nodule which are formed especially on the lower limbs, on the shin area or anterior part of the tibia. There may be periungual erythema around the nail. There may be redness. There may be dilated capillaries there. There may be alopecia. This alopecia is a patchy type of alopecia. You have already seen the picture. And some of the very, very important points are heliotrope eyelid and Gottron's papule. Heliotrope eyelid and Gottron's papule, which are the hallmarks of dermatomyositis. These heliotrope eyelids are some of the red type of lesion present in the upper eyelid. Okay, I have collected a picture probably here. I'll show it. And Gottron's papules are present on the finger. Okay, especially on the joint area, small joint of the finger. There is a thickening, redness of the skin. Okay, this is known as Gottron's papule. Now see this. So this lady is having different type of rashes on the face, and she's having some ulceration on the tongue also. So this is one of the important feature of connective tissue disorder, oral ulcer and skin rashes. Now see here. This is the hand of a normal person. We can pinch the skin very easily because subcutaneous tissue is there and skin is not attached to the underlying surface. But see here, the examiner is doing the same type, isn't it? Same type of test, but I cannot see any skin fold there because it is very tight. It is very tight. So this is one of the tests which you can do in scleroderma or systemic sclerosis. Remember the name, quite catchy name, easy to remember. Remember, sclero means sclerosis. Sclerosis is fibrosis or thickening, and derma is the skin. So thickening or fibrosis of the skin is known as scleroderma. Now this is calcinosis. Calcinosis. This is a calcium deposit on the different area. And this is digital ulceration. And this digital ulceration is mainly because of ischemia. Probably this person is having Raynaud's phenomena. At the same time, there is some problem in the nail bed also. Now look at here. This is known as heliotrope rash. Heliotrope rash. Don't forget it because it can be a very, very pathognomonic finding of dermatomyositis. If it is present, you can think about that condition and then confirm it later on with the help of lab investigation. These are catchy type of physical examination finding. Heliotrope rash, dermatomyositis. See here on both sides. Heliotrope rash, this lady may be having dermatomyositis. Now these are called Gottron papule. Look at this small joint of the hand. See here. Okay, this type of finding, Gottron papules. These Gottron papules are also seen in dermatomyositis. Dermatomyositis. These are the small dilated capillaries, also known as nail fold capillaries. Okay, you can call it telangiectasia as well. These are highly suggestive of connective tissue disorder. If somebody is having this, and if we see it very carefully, if they are present, we can suspect connective tissue disorder in that person, and then we take a good history, do other physical examination, and try to diagnose it. Now let's move further. What are the other types of physical examination finding? If we examine the eye, there may be conjunctivitis, red eye. There may be scleritis or episcleritis, again red eye. Uveitis also results in red eye. Iritis also results in red eye. Or if it is a case of Sjogren syndrome, we call it keratoconjunctivitis sicca. Kerato is cornea. Conjunctiva is conjunctiva itself. Sicca is dryness. So the eye is completely dry in this disease. So this is Sjogren syndrome, and other types of manifestations are seen in other connective tissue disorder also. Examine salivary gland. Now salivary gland are again involved in Sjogren syndrome. So because of that, there would be xerostomia. Now xerostomia is a dry mouth. Xero is dry, ostomia is the mouth. Okay, the combination term, dry mouth. And salivary gland enlargement is very typical of Sjogren syndrome. Reticuloendothelial system will show lymphadenopathy or splenomegaly. Okay, these are quite commonly seen in connective tissue disease. These lymphadenopathy are generalized type of lymphadenopathy, and many of them are, you know, non-tender because this is not a case of infection. Examination of the lung shows rales, okay, wheezing, maybe pleural effusion or pleural rub. Now, rales or crepitation, especially if there is inflammation going on and if there is a accumulation of fluid inside the alveoli. Okay, wheezing, if the bronchus or bronchi or small airway are become narrowed. Pleural effusion, again, this is because of fluid collection in the pleural space. Now, can you tell me which type of pleural effusion it would be, exudative or transudative? Which pleural effusion is this in connective tissue disorder?
Transudative, sir.
Why transudative?
Because, sir, exudative is mostly in infection, sir.
No, listen here. Exudative is seen in inflammation as well as infection. Okay, you remember that? Yes, definitely in infection there is exudate, but also in inflammation. Remember, inflammation can lead to capillary dilation. So there is leaking of the fluid, and that fluid is always rich in protein, and that is called exudate. So this is an exudative type of pleural effusion. Transudative effusion are mainly seen in heart failure, nephrotic syndrome, cirrhosis of the liver, or hypoproteinemic situation. Pleural rub. This is a feature of pleuritis. There is inflammation of pleura, so pleural rub can be heard. Examination of the heart, okay, will show us the enlarged heart, okay, or a dilated heart, maybe features of pericardial effusion. This enlarged heart is mainly by pericardial effusion. Just like pleural effusion, there is fluid collection in the pericardium also. There may be murmur, there may be pericardial rub, there may be edema as a result of heart failure, arrhythmia, or sometimes even abnormal P2 sound. This is second component of the second heart sound. Second heart sound has two components, A2 and P2. So abnormal P2 occurs because of pulmonary hypertension, means loud P2 may be there. Regarding the vascular types of physical finding, patient may be having acrocyanosis, okay, acrocyanosis, bluish discoloration of extremity, absent pulses as a result of vasculitis, arterial or venous thrombosis, very, very common in case of connective tissue disorder. So these are some of the important physical findings. See, this topic is very broad. So what I'm trying to explain here is the concept. If these are the things, maybe even 10 to 15% of the concept you take from this class, you can suspect, yes, this lady is having connective tissue disorder. So let me take a good history. Let me give some more time to her. Let me send some investigation. Or if I cannot, I refer this to my senior. I don't send her home just like that. This is the take-home message. Now in GI, okay, so many, this almost whole body is affected in connective tissue disorder. So in GI system, what happened? There may be hepatomegaly, there may be gastroesophageal disease. One of the condition is esophageal dysmotility. See here is written, or malabsorption syndrome. So this can be there in GI. In muscle, there is tenderness of the muscle, atrophy of the muscle, or proximal myopathy. The person even cannot stand, okay, from the sitting posture, or patient cannot raise the hand or the upper limb. To raise the upper limb above your head, you need the function of proximal group of muscles on the upper limb. So if they are weak, that function cannot be done. Regarding the joint, there may be joint tenderness, joint swelling. Okay, this swelling is caused by inflammation. So at the same time, there is collection of the fluid in the joint, which is known as effusion. There may be inflammation of the synovial membrane. This is known as synovitis. Or in some of the disorders like rheumatoid arthritis, there may be deformity of the joint as well. This is one of the very important feature of rheumatoid arthritis. SLE and other types of connective tissue disorder, they do not lead to deformity of the joint. Regarding the nervous system, okay, the patient may be having neuropathy, that is cranial nerve palsy, or peripheral neuropathy. They may be motor or sensory, or they may be entrapment neuropathy. Entrapment neuropathy, remember, one of the conditions is carpal tunnel syndrome. Carpal tunnel syndrome. This is a perfect example of entrapment neuropathy, because that median nerve is trapped in the carpal tunnel because of some deposition there, or because of proliferation of the tissues there. So there are so many causes of carpal tunnel syndrome. So it may be one of the cause for that. In the central nervous system, the person may have some psychiatric symptom. So psychosis may be one of the manifestation there, and personality change may also be the manifestation by damaging central nervous system. So many physical findings are there of connective tissue disorder. Now, what investigation we like to order after going through the history taking and physical examination? It's a turn of investigation. Lab test must always be interpreted in the light of the clinical context. This is so important one. You cannot order all type of lab test. There are hundreds of the lab tests. I cannot order all of that in a single patient or in my patient. So what are the tests we order? What determines that test? It is from my finding, what I got from the history taking and physical examination. After that, I should make one provisional diagnosis, and accordingly, I will order the test. And during interpretation also, I will always follow what findings I get. Accordingly, I will do. Otherwise, there may be a mistake. Approximately 5% of the general population have a clinically irrelevant positive ANA in the serum, especially in female. So a positive ANA in isolation may have no diagnostic significance. This is very important point. So let me explain again. If a patient comes to us with something else, some other clinical feature, we are not suspecting connective tissue disorder here, or a healthy person, for that regard, and you have done ANA. ANA comes positive in her. No symptoms, no sign, nothing. So just ignore that report. This ANA may be just present in 5% of the population. It doesn't have any value. In contrast, someone with photosensitivity, someone with inflammatory arthritis, or recent pleurisy or pleuritic chest pain may have a 50% pre-test probability of SLE. Already, they're having multiple features of SLE there. So on top of that, if ANA is present, then it gives us the diagnosis. This is the point. Now, these are the different types of tests which we can do in a case of connective tissue disorder. So many tests can be ordered here, okay? But you should give a little bit reason for that. CBC, if it is done, it may demonstrate leukopenia, lymphopenia, and thrombocytopenia. See here. Or some of them may present with hemolysis also. Leukopenia, the total WBC count less than 4,000. Lymphopenia, okay, less than 1,500. Thrombocytopenia, less than 100,000. That is a platelet count, of course. Or there may be evidence for hemolysis because autoimmune hemolytic anemia may be a part of the process. So that is important one. So in short, this is a case of pancytopenia. Urine dipstick and renal function are always done because kidney is almost always affected by any connective tissue disorder. Kidney function tests are absolutely important here, and many of them are having hypertension also, so kidney function test is always done. Creatinine kinase, many of them damage the muscle also. Myopathy is one of the important part of connective tissue disorder, so you check creatinine kinase as well, whether it is elevated or not. Acute phase response or reactant are routinely checked, like CRP and ESR. These are called acute phase reactant. So ESR is frequently raised in the connective tissue disorder, while in contrast, the C-reactive protein may be normal, particularly in SLE. Okay, but in other, the CRP also may be high, and CRP is mainly high in infective condition. Now, regarding some serological test, okay, we can go for ANA and certain other tests which will give us the diagnosis. ANA is a screening test. It is a sensitive test. So it is positive in almost more than 90% of the patient. Sometimes, even 100%, all of them. But remember, in 5% of them, it may be normally present. So apart from them, we go certain other types of antibody test. Now, what are the other, important type of test? See here. A lot of MCQ question can be asked from these slides. Okay, so please pay attention. This is a rheumatoid factor, ANA, and VDRL. We already talked about ANA. So rheumatoid factor and VDRL can be done here. Now this VDRL is done for syphilis. RPR and VDRL are done for syphilis, and these are very non-specific. Okay, treponemal antibody. So they may be present in other situations. So connective tissue disorder is one of them. So that's why they may be done here also. And remember, if VDRL is present in connective tissue disorder, please do not interpret as this person is having syphilis. The point is not that. He may be having syphilis, okay, that's a different thing. And to confirm syphilis, I can go for some specific treponemal antibody test. Okay, that's a different point here. But presence of non-specific treponemal antibody do not mean the person is having syphilis. It may present in other situations like this. Other studies to consider would be C3 and C4. Now, C3 and C4. Now, let me ask you one question. If C3 and C4 levels are low, what does that mean? Anyone? In connective tissue disease, if C3 and C4 levels are low, what does that mean? That means they are utilized. Okay, they are utilized. Probably type 3 hypersensitivity reaction is going on, and they are utilized during that reaction. That's why they are decreased. That type of information we get. Anti-SSA and anti-SSB antibody, also known as Rho and La antibody. Rho and La. Okay, these are important type of antibody which are present in systemic sclerosis. Sjogren syndrome. Smith antibody, okay, is a part of SLE. Anti-topoisomerase antibody and sclerosis 70 antibody are seen in systemic sclerosis. And anti-cardiolipin antibody can be seen in so many different conditions. Okay, they are again non-specific type. Now, what's the role of imaging study in these connective tissue disorders? So chest X-ray is usually done, and chest X-ray provides us so many important information. See this. Chest X-ray can show lymphadenopathy in the mediastinum. It may give clue regarding the interstitial lung disease, pleural effusion, pulmonary infiltration, pericardial effusion, or even cardiac chamber enlargement. Depends on the situation. If myocarditis is there, then cardiac chamber may be enlarged. Otherwise, if only cardiac shadow is enlarged on the X-ray, it may be because of pericardial effusion as well. CT scan or computerized tomographic scan, especially high resolution CT scan, can define anatomical intrapulmonary abnormalities more clearly. Okay, so if you are confused with some other pathology like bronchiectasis, sometimes interstitial lung disease, then CT scan can be done. And pulmonary function test can be done because these connective tissue disorder, they lead to restrictive type of lung disease, restrictive type. So just to confirm, we can go for pulmonary function test. What are the other tests? See there. Important questions are again can be asked in the exam. Echocardiography. Now, echocardiography can show different features of heart function. What is the chamber size? What is the function of the heart? What is the ejection fraction? Isn't it? And how much pericardial effusion is there? So all that information is provided by echocardiography. Now, in case of Sjogren syndrome, we can do one important type of clinical test. This is not a lab test. This is a clinical test that is known as Surmer's test. Okay. In ophthalmology, I'm sure you have studied this already. Surmer's test. Now, what is this? It is useful to screen for dry eyes, secondary to decrease tearing in association with primary or secondary Sjogren syndrome. And in this condition, okay, we put a small, strip, okay, a small paper strip in the conjunctival sac, and after certain time, we see how much of that paper strip is wet. So accordingly, we make interpretation. This is known as Surmer's test. So in a bit of detail, it is explained here. A young person normally moisten 15 mm of each paper strip. This is normal. 15 mm of the paper strip is moistened. Because of Sjogren syndrome or because of hypolacrimation, okay, 33% of the normal elderly person may wait only 10 mm in 5 minutes. Now, this is because of the aging process, probably nothing has happened to them, but even because of the aging process, hypolacrimation occur. So around 33% of the normal elderly person may wait only 10 mm in 5 minutes. Young person can wait 15 mm, but because of the age, 10 mm maybe wait. So this is an important point here. Okay, now see there. But if the same person is having disease, now what will happen? The person with Sjogren syndrome moisten less than 5 millimeter in 5 minutes. So in comparison, this is 15 millimeter. So here 5 millimeter. Even if that person is older, at least 10 millimeter can be moistened. So there is a clear-cut decrease in length of that paper strip which is moistened. That means the person is not producing any tear. That is the conclusion. This test also can have an abnormal result in patients who take anticholinergic medicine. So can you give me the example of anticholinergic medicine? What are those? Anyone? What are anticholinergic substance or medicine?
Sir, atropine like homoatropine.
Very good.
And other drugs.
Excellent. Atropine and related compound. If you say that, your teacher will be very happy. Atropine and related compound like homoatropine, okay, scopolamine, isn't it? Ipratropium, all those drugs are there. Okay, all of these are anticholinergic substance. Another type of investigation is a nail fold capillary microscopy. Now remember, we already talked about this. In many connective tissue disorder, there will be dilated and tortuous capillary loop, okay, in the nail fold or nail bed. Now there may be decreased number of capillary if active Raynaud phenomena is going on there. In the other hand, there may be formation of some new capillaries also there. So it depends which type of disease is there. Accordingly, examination finding would be present. This may be decreased, which is known as dropout. Some areas of avascularity would be there, or known as dropout. This is because of ischemia. Whereas in other condition, there may be telangiectasia, means more number of dilated blood vessel may be there. So both type of features may occur. Now at the end, okay, we have come towards the end of this important clinical topic. See there, these are some of the important connective tissue disorder, and these are the presenting signs or symptom, and these are the presenting lab data. You can expect a lot of MCQ question from here. So let's let's go through them. SLE, or systemic lupus erythematosus, is a very important type of connective tissue disorder. So there are a lot of criteria. This is known as ACR criteria. We have got 11 criteria there, and out of that, 4 should be present for the diagnosis. Fever, photosensitivity, serositis, alopecia, okay, hematological abnormality, renal abnormality, central nervous system abnormality, all those things are here. Now ANA, anti-nuclear antibody, double-stranded DNA antibody, anti-Smith antibody, anti-cardiolipin antibody, and leukopenia. All of these are important features of SLE diagnosis. Okay, among them, anti-double-stranded DNA is very, very specific. Systemic sclerosis or scleroderma, we have sclerodactyly, okay, and Raynaud phenomena. So many other features are there, but they have only listed the important one here. And ANA, okay, and anti-centromere, anti-SCL70 antibody may also be there. Sjogren syndrome, we have xerostomia and xerophthalmia, and we have SSA and SSB antibody, also known as Rho and La antibody. Rho and La, they're quite a commonly used term in clinical practice. Mixed connective tissue disease, we have esophageal reflux and Raynaud phenomena, and we have ANA, anti-ribonucleoprotein antibody. Okay, ribonucleoprotein antibody. And polymyositis and dermatomyositis, we have proximal muscle weakness. So there may be ANA or may not be ANA sometimes. Okay, anti-PMSCL, anti-Jo1, and anti-MI2. These are all different types of antibody which may be present there.